Welcome back to the Hope in the Valley series. I'm your host, alongside with Dr. Ashleigh Herrera. We want to explore what it takes to break stigmas and rebuild hope in our communities. Again, Dr. Ashleigh Herrera is a licensed clinical social worker, researcher, and founder of Hope in the Valley. Her focus is to expand practical life-saving resources and improve health equity for people impacted by opioid and stimulant use here in Kern County. Each episode, we're going to go ahead and sit down with the people that are working in the front lines, doctors, researchers, and community members to talk honestly about what's working, what's not working, and how we can support the health and well-being of our community. For this episode, I've invited Dr. Ricky M. Bluthenthal. Dr. Bluthenthal is a distinguished figure in his field, serving as a professor and chair of population and public health sciences at the Keck School of Medicine at the University of Southern California. Since 1981, he's been a leader in community-partnered research focused on risk behaviors, drug use-related health problems like HIV, HCV, and crucially, efforts to prevent these negative health outcomes amongst disadvantaged populations. He's published over 200 manuscripts, and his work has been funded by major organizations like the NIDA and the CDC. I'm especially impressed by his history, being a founding board member and a co-founder of the Syringe Service Program in Oakland, California. His deep experience in public health and compassionate approach to prevention is essential to this conversation. And now, here's our episode. All right. So now this is episode 2 of Hope in the Valley series. We are here with Dr. Ashleigh Herrera and Dr. Ricky Bluthenthal. We have our awesome grant with Hope in the Valley, and we're going to go ahead and be talking about medication-assisted treatments, and we're ultimately going to go ahead and talk about a lot of the discrepancies that affect a lot of marginalized areas. Dr. Bluthenthal, tell us a little bit about yourself outside of what was, in the intro. What are your hobbies? What do you like to go ahead and do outside of the work that you do?
Hobbies?
Hobbies, yeah.
Yeah, I don't know that I have hobbies. I probably play Civilization 5 too much. I watch English Premier League soccer, and I go for an hour-long walk every day. So I think that's probably about it at this point.
That's awesome. Great to hear. I'm such a huge fan of the work that you've done. I've been able to go ahead and do a little bit of research on you since we were able to go ahead and get you on. And I'm super proud of the work that you've done, especially the BIPOC community, those that are disproportionately impacted. What made you want to go ahead and get into this specific work?
Well, I'm a sociologist by training. And the reason why, aside from enjoying doing research, the reason why I got a Ph.D. was because I thought that, science could offer a truer view of what was actually happening with minoritized populations. And so I really devoted a lot of my adult life to either trying to use science to provide a broader version of truth or in support of service providers and policies that help us deal with the structural challenges that are most of the explanations for the health disparities that are experienced by minoritized populations.
Yeah, very similar to a lot of the work that you've been doing, Dr. Herrera. Is that fair? Safe to say?
I would say that Dr. Blutenthal's work is a lot of the inspiration for the work that we're doing. When we connected over 2 years ago, he really encouraged me to push further into this space in terms of our life-saving overdose prevention work and infectious disease prevention work, more so on the ground, and understanding, what is the value of being able to provide these services and then also connect them in terms of our work in science to not only witness and observe, but some of the things that are going on, especially in these challenging times where there's been, intensification of criminal legal approaches to dealing with substance use, but also what interventions could actually work when we center populations at highest risk. So Dr. Blutenthal's work is very formative to my own. So we just hope it's a reverberation.
Absolutely.
Well, thank you.
That.
Those are very kind. I mean, you're doing great work, Ashleigh. So I'm excited to have anything to do with your story. So thank you for involving me.
Oh, thank you.
Dr. Bluthenthal, I'm curious to know about some of the data. You've done over 200 publications that's been peer reviewed. What does the data show, specifically when it comes down to how opioid and stimulant use disproportionately affect communities of color?
Yeah, I mean, I think it's helpful to start at the beginning, and I'll just use my career as sort of a prism to do that. The first research Not the first research I did, but the first research I did in this area was on HIV epidemiology among people who inject drugs. And I led a study in Oakland and East Palo Alto and Richmond, California, where we found elevated HIV rates, the highest rates on the West Coast. In fact, the highest rates west of the Mississippi. So it was 20% in West Oakland, 30% in Richmond, and a third of the people in East Palo Alto. So it was a big deal. So the epidemiological component of my career asked the question, why was this happening in these neighborhoods? And so my dissertation sought to answer that question, and the answer was, look, if you look at the individual behaviors of Black folks and white folks and Latino folks all in these same settings, what you find is, they're all elevated. So there's something about the neighborhoods, not racial differences in risk. In fact, in all of these studies, African Americans and Latinos were actually less risky than their white counterparts. So it made me turn towards looking at, what was going on in those communities. And what we found is a story that persists today, which is, over-policing. And there's a direct link between police activity and HIV transmission among people who inject drugs, mostly because more active criminal legal involvement means people carry syringes, they'll be less likely to use needle exchange programs, and that ends up creating the conditions where HIV can more efficiently spread. But those neighborhoods, those communities, those three communities had a shared history of a variety of adverse policies beginning at the federal level, from redlining to federally supported things like slum clearance and urban renewal, which tended to reduce the capacity of the neighborhoods to take care of themselves and broke up the social cohesion that all of us sort of count on to be able to live in safe communities. And in particular, West Oakland, where I spent the most time physically, you saw, beautiful homes that had been built in the Victorian age and late 1800s, or these beautiful Victorian buildings, which because of redlining couldn't be repaired because no one would give loads in those communities. And so they became dilapidated and then created space in communities for mischief, for want of a better term, and social disorder. And then West Oakland got this treatment, got the water treatment plant, so the place smells bad. They drove the previous 80 freeway through the middle of the neighborhood, breaking up social cohesion. And so you had this sort of environment that was very ripe for the spread of an infectious disease. And so that's sort of where we started. And then the other thing that happened that, this still hurt my heart is probably too strong a term because it's been such a persistent reality. But in the response to HIV, which we just hats off to the gay community and the lesbian community and the transgender communities, which really mounted a vigorous and profound political response to their version of the apocalypse. And so, there's a lot of effort put into protecting people from HIV, but a lot of that effort ended up being focused in white communities. And some of that was because in this early period with injection drug users and ACT UP, the ACT UP group wasn't from the Black community, and so they didn't go to the Black community. So I'm not blaming them, but I am, pointing at because in fact, the needle exchange program that I helped start in West Oakland and in East Oakland in 92 was funded by ACT UP. So they were happy to help, but they just didn't have the cultural competence or the familiarity to go in there and do the work. And so one of the things that turned out is early in the sort of needle exchange movement in North America, in an African American community. And I think that has continued. So even now, when we look at naloxone distribution, my colleagues and I'm jumping ahead 25 years, did an analysis of San Francisco and Los Angeles, and we found that African American, Latino people who inject drugs in both of those communities were less likely to have naloxone on them. And so they were at greater risk for overdose death as a consequence of that. So I think you have the structural issues. You have the social movement part of the HIV/AIDS response, which is big reason why we got certain service programs in the United States at all. There are Black people doing needle exchange programs, just not enough. And, in fact, we now have the Black production coalition, like a new organization, which is trying to correct that decades-long disparity in response. And when I look at Los Angeles, even as an example, the most robust syringe service programs are in downtown, which is good. So in Skid Row, and that's, disproportionately African American. But when you look at the historic African American communities in Los Angeles, they're less likely to have the same robust syringe service programs. And it's true also in the Latino community. So when I look at LA, we have syringe service programs in East Los Angeles. They're just not as robust, and they haven't managed to penetrate. And, I think it's a complex story. So I think some of it is these structural disadvantages. Some of these communities have lots of issues. And so the activist energy in those communities isn't often focused on people with, opiate use disorder. It's focused on children getting TB or food insecurity, or getting better policing. So that are issues that sort of hit everyone. So I think one of the challenges has and remains, given the epidemiology, which tells us in particular, older African-American men, Latinos are increased risk of overdose death now. How do we respond to that? What, do we even have the community infrastructure to get people the naloxone they need, or to get them access to buprenorphine, or get them access to methadone so that their risk will be lower? So I think they're big challenges. They're long-standing challenges, and they're complex challenges.
Absolutely. Dr. Herrera, what have you been able to go ahead and see in Kern County based off of the research, just kind of piggybacking off of what?
Well, I think one of the concepts that Dr. Bluthenthal brings up is this idea where he's always asking us to think about what's the role of surveillance and how people are making decisions around how they're able to engage with different kinds of services, whether that's, uptake of naloxone or, engage in infection prevention measures. And oftentimes when we are engaging people around naloxone distribution, they're picking up other supplies. And then we say, okay, would you like any naloxone today? And we definitely hear people say, well, I don't use opioids, so I don't need to carry that, right? Mm-hmm. And this idea, well, I don't do that, so this isn't going to happen to me, so I shouldn't have to take this. And so that's something that I think we're doing a lot of psychoeducation around, that this is a tool for you to save other people. Just because you have it doesn't mean that it's indicative that you're using drugs or you're using opioids. And so we're trying to do the reframing on the messaging, but there's a lot of stigma about carrying naloxone because then it would designate that you are someone who uses drugs. And then there's also some tensions in the community about, well, I'm using other kinds of drugs and I'm not choosing to use fentanyl, so I shouldn't have to be responsible repeatedly for reviving people who are using fentanyl and not taking efforts to move towards recovery. And that's been really hard to encounter in the community, and try to have the people who are most vulnerable create this sense of how do they protect one another, because certainly there's not enough coming from outside their communities to help them.
Right. Do you feel like Hope in the Valley has been able to go ahead and work towards that, the destigmatization of that within those communities?
We're trying. We were part of an RTI study, the cyanaloxone study, so we got a lot of support on just continuing to ask people on an opt-out basis around naloxone and continuing to reoffer training. And we retrain people around compassionate overdose management. And we really try to push out the messaging that this is a life-saving tool. It's like first aid. It's good just to have. But I think we're looking into additional interventions for behavioral reinforcement so that people do, improve their engagement with the naloxone cascade. So we have a collaborator, Michael. He's got some really cool ideas. It seems like we might get some funding next year to explore it and see if we could use a contingency management approach to reinforce consistent carriage of naloxone. So that would be great to see if that leads to some changes. So, always where can we, draw upon evidence-based principles like operant conditioning, which is very established science, to improve these areas where we see that folks are really highly impacted and are struggling to overcome some structural barriers, but also internal barriers related to stigma and shame.
Absolutely. What are your thoughts on that?
Yeah. I think yeah. Sorry, I'm not being very articulate right now. I think a couple of things going on. So, you should never understate the impact of the law on the street on these behaviors. So what do I mean by that? The California has Good Samaritan laws. Everyone should feel free to carry naloxone. That doesn't mean if you have it on you, police regard it that way. So that's one thing. The second thing is that, many people who are using opiates or injecting drugs find themselves unhoused. And so they end up in encampments. And what happens in encampments? Well, they occasionally get swept, sometimes, regularly. And when that happens, what gets thrown away? Well, everything gets thrown away, including naloxone and buprenorphine and syringes and food and clothing and pets. Everything gets thrown away.
Right.
So there is this ongoing system that's pretty profound that's intervening, right? In the same way that Dr. Herrera is trying to intervene. The system, our society is intervening and both hurting folks materially, but also psychically. I mean, one of the things that I think it's difficult for people who've been housed, as I have all my life, to get is what happens to you psychologically when you're unhoused and the kind of stress you're under and paranoia and fear that's just coursing through your body all the time because there's so many threats in the environment to your well-being. And, what we've done in a lot of the research that has been led by my doctoral students at this point now, we've taken an ontological security approach to these questions. And so what's ontological security? Well, it means if you're going to be in a position to take care of yourself, you need to have material constancy. You need to have social support. You need to have privacy and freedom for surveillance. And none of these are things that people who are unhoused and using drugs have. So, when we then step in to try and say, hey, you can do this thing that might save someone else. I mean, that sounds great. People generally want to do that, but there are so many other things on their mind that getting them to sort of faithfully hold on to those medications because of the risk and because of what's happening with encampment sweeps, I think it's pretty challenging. It's a heavy lift. And, in some ways, when I think back on my career, it's now been almost 35 years I've been looking at these topics and appreciating how difficult our existing political economy is on these groups of people. It's a wonder we have ever had any success.
Yeah.
But we have. And, and that's because at the end of the day, if we can give people things that they need and good reasons to use them, they're going to make the changes that will support their own well-being. And that's what we know from syringe service programs. That's what we know from overdose response. And it's really been fundamental in reducing the scourge of HIV in communities of people who use drugs. It's helped bring down the overdose death mortality, the sort of epidemic that we continue to be in the midst of. But we have to empower these folks. We have to respect their agency, and we have to recognize that some of the things that are really popular with housed people actually are really deadly for unhoused people.
Absolutely.
And if we can center as Dr. Herrera pointed out, center their experience of the environment, we're better able to understand how we might want to manipulate things in a way that would allow them to not be at such risk for overdose death or hepatitis C or HIV outbreaks.
Yeah, exactly. Go ahead, Dr. Herrera.
So Dr. Bluthenthal has this great postdoctoral researcher on his team, Dr. Ganesh, and she's done some really incredible research. And she came out with this qualitative paper that really, I felt, helped people to understand more the realities of folks trying to initiate MOUD on the streets, and that they can't afford for it to hurt so bad. And that quote was so key to understanding why do we have so many failed attempts? People are interested in making a change, right? They're tired of waking up every day and being sick and having to get well and all of the struggles and heartaches every day in the process to be able to accomplish that. And they want to move towards a space of more stability and recovery. But the process of initiating MOUD is so painful, and they don't have a safe environment to do it. And so they don't have the facilitative conditions to make that change. So something that's happened here locally in Kern County, which is really exciting, was that the executive director of our homeless collaborative is somebody who worked in LA before and was working with the mayor's office and got the job here. So brought a lot of really great best practices to Kern County. And he said, you know what, we have motel vouchers. So, we didn't know that. And so we were able to support this couple that for months we were trying to help them initiate MOUD. We said, what if we got a motel? and so that you could do this and not have to do it on the street and be so sick on the street. And they were successful to onboarding onto methadone and now are at one of our low barrier transitional shelters, getting their
awesome.
medication every day. But for months, we struggled with this process. We tried to onboard with Suboxone, try to do methadone on the street, and it was just failure after failure. And they really wanted to get into the shelter, but they knew with their level of use, they wouldn't be able to, stay there and follow the shelter rules. So this was our plan, and we just kept failing until we had the resources they need to support recovery. And that's housing. Housing is healthcare.
For sure. And MOUD is medication for opioid use disorder for, just for anyone that just may be listening to this and may want to have a better understanding of what that means. So in order to go ahead and get MOUD services, of course, getting in contact with a medication assisted treatment or a MAT team. Those are things that you as a family member could go ahead and reach out, get in contact with a behavioral health or a substance use team, and they'll be able to go ahead and connect you with those services. But I definitely want to go ahead and go back and touch base because this kind of ties into the next question that I have for you. When we talk about these encampment raids, it becomes a psychosocial stressor. And that's kind of where my work comes in as a clinical social worker, where we start talking about, well, my stuff is gone. My best friend, which is a pet, they are now gone. For them, their family. It's not just a pet. And I could definitely understand that as a dog owner myself, that for them is, for anyone that may be housed, they may see it as like, oh, it's just junk. They'll go ahead and no, it's not. That is their entire lives. And that is such a misconception when it comes down to obtaining services, because when they're about to go ahead and work towards receiving the MOUD or getting connected with MAT services, they're at that state, and then a major psychosocial stressor happens, which then causes them to go ahead and continue that cycle of abuse within their dependency. So the question that I have for you, tied into that is, what are some gaps that exist in current preventions and treatments, if it's in research or even in the practice setting, specifically for Latinos, Blacks, Indigenous, and Filipino communities?
Well, I think one gap is patience. I think Dr. Herrera just gave a great example of, you can't, dig a hole for people and expect them to flip a switch and suddenly they're out of it and everything's better. So I think having patience is one thing. Another issue is that so many of these programs are siloed. So in this, you'll get to this part, Dr. Herrera, of when you're trying to move them out of the transitional housing and you realize, okay, so the group that we use to get them the apartment, the group that we need to get them furniture is a different group. And so we've got to figure out how to, and then the people that get them food is a different group. And so then and so we make it really hard for people. And again, remember, it's one thing to ask, hey, upper middle class Ricky with a Ph.D. and a stable job and who's never, you negotiate these things. I probably do okay. But, you're dealing with, a drug dependence, you're dealing with, massive trauma, psychological trauma, physical trauma. Many of these people have injuries that are poorly treated and haven't healed appropriately. They have chronic health problems. They got all the things. And then we send them into this labyrinth of like obstacles and timing and needs for transportation, and then ask, why aren't they better? And so, really what I'm looking at is, hey, the people that have the resources are the rest of us, right? If we're compassionate and focused, we can actually help people like Dr. Herrera just shared. But we have to be patient. We have to realize, it's going to take time. We're going to have to get rid of all the silos that we intentionally put up so that people don't use the services, because we don't really want to help people just as a political choice. And, and dig in and be in solidarity.
I agree. And I think the design, is centered around people who are housed and, are somewhat able to have constancy in their material basic resources, but they're not designed for everybody else. So one of the things that we encounter here, when we're out on our street medicine work, is that the doctor will put in a referral for, laboratory work or radiology, but then they're like, well, the patient must call themselves to schedule. Well, the patient does not have a cell phone. how are we ever going to get to the next step unless someone stays with them, makes the call? Then we've made the call. They can't get a reminder. They don't know what day of the week it is. They don't have a calendar. They don't have an alarm, and they don't have transportation. So it's going out repeatedly to make contact with them, remind them of the steps, to be able to engage in it. So it's like, okay, you drink a lot of water the days before your appointment, but don't drink or eat anything the day of your appointment so that you can get this scan. And let's hope you remember that. And I hope I can find you the morning of at a time that you don't know what time it is, so that you get in my car and I could drive you from this rural area into Metro Bakersfield.
Or even find you, right? Or even find you, right? Because
Yep.
I think the other thing is that, so, we've talked about the encampment sweeps, but look, the other thing is these are people living under stress. So, their social relations come and go. Right. So, they might be in an encampment and everyone's getting along, and then suddenly they're not getting along. And so now they've got to be at another place and you don't know where it is. So, I do feel like patience, and then also just coming to them with a set of resources that is flexible and that might be used creatively. So the story I like to tell is there was a LEAD program, so law enforcement assisted diversion, that CHPLA was doing in Hollywood. And they just had, their case managers were, I'm a former Catholic. I mean, they were like saintly, like they were down. And there was a circumstance where one of the women, who was a transgendered woman, was in a residential treatment facility that had to close for some reason. And so there was a real scramble to try and get her into another facility. And they found one, but it was one where she had had a really negative experience previously and she didn't want to go there. And the case manager, he just pivoted. He said, okay, look, I need more time. Let's buy more time. Tell me, what can I do right now that would make you feel better? And she's like, hey, you know what? I grew up in Huntington Beach. Can we just go down there? He's like, yeah. And he took her down there and he found her a motel. They hung out at the beach for a while. And as the day was ending, she says, my mom lives here. Can we reach out to her? He's like, yeah. Facilitated the phone call. She had a great talk with her mom. Her mom met her the next day. They hung out the next day. Meanwhile, this case manager and his team, they're on the phone. They're calling in favors. They're trying to find a place that's going to work for her. And they did. And, by Monday morning, he comes down, he picks her up. Boom, they're in a new facility. It's a place where she feels comfortable and she can continue her road to recovery. I mean, it's an extraordinary story, but it underscores, like, if we want to make it work, we can. We just have to empower ourselves to do it. In a lot of the ways I think about it, and, in some ways, the most important thing I've ever done in public health was, as a 25-year-old person, recognizing there was an HIV outbreak in West Oakland and saying, I'm going to be someone that actually helps solve this. So we all have that opportunity. We just have to give ourselves the permission to engage and be in solidarity and love on people who have not been loved on, and give them the support they need to find a pathway to better health and better well-being. And, it's no different than, what my wife and I have done for our own kids. I mean, we do the same thing. They got a problem, we're all in. Unfortunately, not everyone gets to have parents that have wealth and social capital and, ways to really assist themselves. But we're a wealthy country. We could be doing that for the most disadvantaged people. We just keep choosing not to. And, I'm hopeful that work that Dr. Herrera, hopefully my work, inspires a different approach that recognizes that we can find solutions, but we have to be engaged and nimble and focused on the needs of the population, not some version we have of, what it looks like for someone to be in recovery. Because look, I've never been physically dependent on anything stronger than coffee. So I don't have insights into how to do that for other people, or for folks who are psychologically addicted to methamphetamine use. I don't know how to overcome that. And asking me, even with all of my years of study, to come up with a solution is, kind of hopeless, right? I mean, we have these tools that we're working on, and there's some promising medications, but, that's 30 years in, right?
And so many things have changed.
And they're
within
still
these
not
30
available at the retail level.
Yeah, absolutely. And so many things have changed within these past 30 years as well, in regards towards the way that, everything is, from even from cannabis. Cannabis isn't what cannabis was 30 years ago.
Yeah,
And
this isn't
and
your
then
dad's cannabis, right?
right, this isn't your dad's cannabis, absolutely. And then we get it. Now we get into opioids, we get stimulants, we have fentanyl out in the world, and it's a different field now. And then we have our. I always believe, I always say that mental health and politics are kind of tied hand in hand. The psychosocial stressors that happen in the political world, drugs are more of a response towards mental health, and substance use. It's more of a response towards mental health. It's not because of the fact that someone really desires it, and that's just more of a subjective opinion. I'm curious on both of your thoughts on that.
I mean, people use drugs for all kinds of reasons. And, I think that's the important thing. I mean, look, do I know people who got in too deep, too fast because they were poor decision makers? Sure. But you shouldn't die because you've made a bad decision.
Absolutely.
And, there are lots of people who are doing it, who do it because they're dealing with loneliness, or they're dealing with trauma, or they're dealing with physical pain. One of the things, there's a great study done by the people at the Benioff Homeless Center at UCSF, Kelly Knight and Margot. I can't remember her last name right now. Anyway, they're great people. Look them up. They did a California-wide study on homelessness and found that, about a third of the people who use substances started after they become unhoused, right? And they do that in part because, they have injuries that are untreated, or it's dangerous to be unhoused. So we see this in LA all the time with people using methamphetamines at night to stay awake so they won't get beat up or robbed or assaulted, and then using opiates in the morning so they can rest when it's physically safer.
Yeah, and harder to do so, especially the way that we as humans we're designed, in a sense, to go ahead and rest at night and function during the day, the way that light goes through our eyelids, and it makes it that much more difficult. Absolutely. So then
I think you raised an important point too, Ramon, that we saw something change, right? When we hit this fourth wave of the opioid epidemic, where before, stimulants were likely killing people slowly, right? Because of what was going on to their health. But now with the contamination of stimulants with fentanyl, folks naive to this substance and they have no tolerance and they don't know that it's in their drug supply, and then they're overdosing and dying. And that's when we're seeing this acceleration of deaths, in Black, Indigenous, and Brown communities that previously weren't as vulnerable to this part of the opioid epidemic. And it really has switched a lot of the work for trying to promote awareness that this has happened with the contaminated drug supply. And then what can folks do in terms of life-saving overdose prevention measures in the interim, knowing that they're not intentionally using fentanyl. And so this is a whole new conversation than they've had in the past.
Yeah. So now how do we respond to this? I mean, there's stigma and systemic racism that shows up everywhere. It's in the data, it's in our world, it's in our day-to-day lives. How do we measure and work towards solutions, towards being able to go ahead and do something differently?
I mean, it's interesting. I began my sort of sociological life in the context of this book by Chicago. Well, he left Chicago eventually, but at the time he was a University of Chicago sociologist, William Julius Wilson, and he wrote this book, Declining Significance of Race. And the funny thing about the book is, empirically, he doesn't show the declining significance of race, but what he did know was, hey, if I have a social program that's designed to help Black people, it will become politically unpopular in this country very fast. And so the central insight was, we need universal programs. And ironically, naloxone is kind of a great example in some large measure. So, I think for people in communities of modest to low risk, there's probably the same level of naloxone distribution available to them, regardless of race or segregation. I think where we've fallen down is that in the higher risk groups, like this older cohort of African-American, mostly men, so people my age and older, they're not getting naloxone. And, I'm sure there's some of it might be them, but some of them is also, we're still dealing with the residual of when you have a social movement-based public health response, which is what syringe service and naloxone distribution are, unless your community has activists in it, you're going to miss out. And like, as I said earlier, I think It's not that there aren't activists in the African American community, there are plenty, but they also have a long menu of things to work on. And, because of the stigma against people who use drugs, that group is pretty unpopular. They're not going to be first in line. It's interesting. Last night, I was at a YMCA in South Central Los Angeles, talking to kids about fentanyl risk. And, lots of people have family members who have substance use problems. And just listening to how a few of the other adults in the room were talking about their intimates, the stigma is real.
Mm-hmm.
And, I might have a structural analysis of what's going on, but trust me, my cousins don't. and that also means that they'll be less likely to act when you have a problem in a way that's, that we might want, that's evidence-based, and that would produce an overdose death. Like giving naloxone because they've kind of given up on this person 3 years ago and they made bad choices, so on and so forth. It's a complicated and hard task to overcome.
Dr.
I think
Herrera,
a few
your
things
thoughts?
I think a few things that come to mind was, Dr. Bluthenthal did a study and part of it did show where were these different programs that offer naloxone distribution located, and that you do need to bring programs to where people are most vulnerable versus expecting them, to traverse really far distances when they have limited resources anyway to get there. So if we're wanting to help populations at highest risk, we need to design and center programs, even just geographically where they are, but then taking the time to build trusted community with them so that they feel safe to interact with us. And then how much can we also engage people with lived experience and culturally aligned experience in that work so that we can further that trust in the process? And then also when we think about, universal, right? And so we have such a great opportunity to work with young people, in school systems. And California is really progressive around, now students are allowed to carry naloxone and fentanyl test strips on campus without, they're not supposed to be a negative consequence. Let's see how that's operationalized on the ground. But now that's allowed. And then also that they need to be delivering curriculum around substance use disorder and risk and prevention. And if we're giving that education, tools, and resources to everyone and starting these conversations early and often, we have this real opportunity to intervene at a time point when folks could go down this trajectory where they have increasingly compounded risk over time, with a disease that likely ends in death, right? But how do we normalize and start those conversations and create these points for early intervention? And we really are seeing a state realignment with the Behavioral Health Services Act, focus more on early intervention, in populations 25 and younger. And so at the same time as doing that prevention work, we really need to intentionally engage with folks who have severe substance use disorders and then bringing services to them in a way that is acceptable as well, right? And not centering that on our experience or what's convenient for us, but what makes sense for them.
Yeah, that makes sense. I'm excited for DARE Plus, being able to go ahead and have that within the school systems and see where that goes, because DARE was an effective program for its time. I think that it definitely needs to evolve to go ahead and get with these modern times and have heavier conversations than what we did when we were in sixth grade. But with that said, as we approach the last 20 minutes of our episode, I'm curious to go ahead and discuss with you both what gets in the way. What prevents us from being able to go ahead and have effective preventions and treatments in these communities?
I think I probably should let Dr. Herrera go first because I keep going first. But anyway, I think some of it's political will. These are complex problems that require complex solutions, and our political intelligence in this country really doesn't have the bandwidth to accept those complexities and try and parse the problem up into bite-sized and sort of addressable components. And I'll just give you an example. So I was on a podcast last week called Falling to Freedom, and I was talking with a guy out in Menifee who's the host of it, Chad Lacombe, and, he was really concerned by my message. And, we had, I think, a respectful and thoughtful exchange. And, I think one of the problems is, and why I said to him, look, what you give a 6-year-old or a 6th grader, or even, an 11th grader, right? These are interventions designed for people who have longstanding chronic substance use disorder. They're in what the public health people would call the tertiary stage of disease. And what they need is different than what I needed in 6th grade.
Absolutely.
And so, but accepting that kind of, like, that sounds silly to say out loud. And of course they need different things, but our political vocabulary doesn't allow us to easily grapple with that difference and accept that both things can be true. So it's fine to tell 6th graders, hey, yeah, look, cannabis is legal, but you're in 6th grade. You probably shouldn't be smoking it. It will be bad for your brain. It will be bad for your social emotional development. And you will end up in some way restricting the opportunities, your life opportunities going forward. That's true. And it's also okay for 25-year-olds to use it, but that's that's complex in our political vocabulary.
Right. Yeah. One, where have you been all my life? That has been the best way to go ahead and explain that. But two, you're absolutely right. And when we have individuals that just continue to go ahead and grapple onto the same debates, it just gets more and more complicated. Wouldn't you agree, Dr. Herrera?
I agree. I think we're not very nuanced in how we view things. We can all use a little bit more gray area. It's very black and white in how we try to approach really complex psychosocial behavioral problems, that are affecting young people and then throughout the lifespan, right? And so when we're able to have conversations with young people in a way that's engaging, we're able to really modify risk, but also that we're providing the structural supports, right? It's not just like we deliver this curriculum, it's that we're understanding what's going on in the social environment and what are the opportunity structures for this young person long term, because we know, like, in a risk environments, and even thinking our community, because here in Kern County, we've got more rural communities going on as well. If people don't see, an opportunity horizon, there's limited opportunity, then that's something that's increasing the risk for substance use and even starting, cannabis use as a young person. That increases their likelihood for all sorts of substance use disorders across the life course that are increasingly deadly and more complicated over time. So that we're really investing again in structural opportunity, not just like, here's a curriculum of XYZ thing for today. Okay. And how are we investing and pouring into young people so that we create something that's new or different, a better alternative to what is there? Like you were saying, is this self-medication because they're struggling with mental health issues that are untreated? Or is this like what a really inspirational colleague, Vanessa Ramos, shared? Like, this was the medicine that was available in my family. This is what I was seeing people use to be able to treat what was going on with them. And this is what my parents shared with me as a way to be able to survive and heal and move through the moment, because that's all that was there. And how do we change that by creating access to opportunity and behavioral health resources?
Yeah,
100%.
I mean, I think, it's funny. Last night, one of the things I said to the kids at the end of the night was, like, you have so much to live for. You just don't know it yet. And the adults around children, they need to be telling them there's such great promise in them. There's so many things that they can do. So, help them find that positive activity that's going to bring them satisfaction, make them see that brighter future and work towards it, and I think a lot of the messages we get with kids that kids are getting is less about what their future is going to look like and more about, hey, can you just be quiet right now? So take your phone or take the tablet or go sit in front of the TV. I need a moment of space. And what those kids need is they need witness and engagement and
Absolutely.
adults around them, helping them find their passion and then supporting them in whatever that passion might be. I mean, again, in this conversation I had with Chad last week, I mean, he had a very difficult upbringing. He made some serious mistakes, but they started early. And one of the things that he did at 12 was he stole a car. And I'm like, okay, so what that 12-year-old Chad needed was an opportunity to go-karting.
Right.
Like, you want to drive something? Let's go-kart.
Absolutely.
And let's make that part of the program. We're going to do it every other week. Here's what I'm not kidding. I mean, those positive reinforcements. You want to drive? Let's drive, but let's do it in a way that's going to be safe for you and pro-social and give you a chance to find the other path. He's found them now, at 50, right?
Right.
Which is great, but he lost 30 getting to that place of peace and purpose that he now has.
Yeah,
And we need to help kids find that.
As silly as that sounds, it's 100% true. Being able to go ahead and, that 12-year-old, version of himself was speaking to a 50-year-old version of himself. And instead of focusing, and I think that's where, we could go ahead and do better as a society. Yeah, a 12-year-old kid sold a car, and of course, there should be some sort of ramifications. However, to go ahead and create a criminal record at such a young age, instead of focusing on creating a solution for this young man and utilizing his strengths, it's a different conversation. And I think that's where we should work towards.
Well, and the truth is, but it's a thing, just real quickly, sorry to interrupt you,
No,
but it's a thing that most parents actually do, right? So it's what ends up happening is when you don't have the material resources, or maybe you're stressed out, so you don't have the cognitive space, the kids end up not getting it. And, we need to say, hey, that happens. So, we could do other things like universal basic income and increase the minimum wage so parents aren't as stressed out. But, we can also create programs in society where kids can naturally find those opportunities to express themselves in positive ways and then build on that to, come up, to be able to create responsible adult personas that we all want people to have.
Yeah, that's fair. And I think as our conversation comes to a conclusion, and we're talking about just younger versions of ourselves, and I think it's interesting that even within this podcast episode that again is hosted by Hope in the Valley, I think that it's really fascinating that even within this episode, we're an ethnic rainbow, and we grew up completely different. We have the white educated female, we have the educated African American, and then we have the educated Latino, which all, for the most part, 2 out of those 3 are, it's like an oxymoron. It just doesn't really exist within the culture. So then being able to go ahead and have these conversations, and then we kind of go back into, well, most parents do that, but then we go back into the culture. In my culture, if a person were to steal a car, oh man, you get the chancla and some. So being able to go ahead and have that conversation with those parents, how can we culturally be responsive and approach these conversations in a very culturally sensitive way to reduce the stigma by also being able to go ahead and build trust within these communities?
I'll let you go first this time.
So first, one of the big pushes that we're having is linguistically accessible services. So are there parents being left out of conversations because all the conversations are in English, especially here in Kern County? If we're talking about, okay, we need parents to be more aware of the risks and talk to their kids about risks and be open to having conversations about really complex, sensitive subjects like substance use or other risk behaviors. But if they're not getting the support in their language to be able to have these conversations with their young people, we're already setting them up to fail, right? Because they're working so hard, they have such limited capacity, and then they're not getting the information and resources that they need to be empowered to be the primary person in their young person's life, which is the role of all parents, right? This is the most significant adult relationship young people have. And are we engaging parents in a way that, again, is accessible and acceptable to them, and in a way that they can understand and modify risk? The other week, we were talking about starting to roll out some of our prevention presentations and working with some of the African American communities and faith-based communities. And then I was asking, one of our colleagues said, well, what needs to happen in the messaging here? And he said, well, people in my community don't perceive this as a risk for them because they don't really claim to use opioids. I said, well, are you aware that, Black communities are facing the steepest, acceleration of opioid-related overdoses? No. And it was the first time anyone asked me, can you put that data in your presentation? Every other presentation, I'm taking out data. So they're like, this is boring. You're overwhelming people with numbers. And he said, you need to show us that this is a problem for us because we're not aware. People are not having these conversations with us about risk. And to me, that's crazy because every paper that I'm writing, this is like in the first paragraph of the intro, right? That this is a health equity issue and people are dying. And what are we going to do about it? And how can we increase equitable access to services and resources? And that's not coming down to the community level is alarming and says that we have a lot more work to do around engagement and then culturally specific messaging and engaging trusted messengers to be able to help us enter those communities and share the messages in a way that's going to be engaging and just hearing what people need. They're like, hey, have a town hall, have a conversation, bring some food, do a raffle, make it interesting. You guys are really boring. You academics. How do you engage people better in a way that's going to be relevant to them. And then even like talking about like the amount of time we should spend talking to young people. We have like a youth engagement consultant, and it's a young man who's been involved with the foster care system. He's 18 years old. And I was like, well, what's the right amount of time? He's like, we have to think we're all on TikTok. So, you need to keep this pretty short. So I've got to really like, even like tailoring it for, the people across the lifespan. What's their tolerance? What's the cognitive load that they can handle? And it just takes so much engagement with people on the ground and being really committed to this iterative design process with them. Because otherwise, people are just going to tune you out, or you'll never get in through the door.
I agree with what Dr. Herrera said.
Anything else you would like to add?
I do, just to bring up this, I am a sociologist, so just to bring up one of the structural realities. And I think this is true in Kern County, just like it is in Los Angeles County. Like if you're a low income Black or brown parent, we don't make it easy on you. And, I think it's important to realize that there's a lot of trauma that comes from the Child Protective Services. There's a lot of trauma that comes from over policing. We know in schools, Black boys and brown boys get punished more severely for the same sort of, infractions, that other kids are committing. We got to do some work at the societal level and recognize that we're creating the problem that we don't want to pay for later. And we could make different choices, supporting parents, making behavioral health services more widely available, making it easier to get drug treatment, but also being less punitive and asking that question, what's going on right now that you're doing this, right? And what might be an alternative to that? That doesn't involve incarceration. Because the other thing is, incarceration is a great intervention if you want to really mess someone's life up. Because when they're in jail, they're not working, they're not learning, they're not developing post-social relationships, and they're going to carry the stigma, literally, of that incarceration the rest of their life. And it's going to interfere with their interpersonal relationships, it's going to interfere with their employment opportunities. It's just a big fat negative. Maybe some people probably do need to be in jail, but we're putting way too many people in jail. And I know that because other countries that are way safer than ours put way less in. This whole choice of incarceration as a frontline response to minor infractions is, as I like to say, bananas. So, and it's expensive and it doesn't work.
Yeah, I could see that. Final set of questions that I have for you both. And we'll start with you, Dr. Herrera. If there's one policy that you could change on a systemic level, and I know that you'll be going to Washington and having these conversations with our elected officials, and if you could change one of those policies tomorrow, if you had that power, what would it be?
Something that I think has been very harmful has been Executive Order 14321. If I had a magic wand, I would rescind that. I think the criminalization of poverty is a travesty. And the solution to poverty is more opportunity. It's not, increasingly punitive measures where Dr. Bluthenthal was saying is it's multiplicative with the harm. Each time you're incarcerated, you've lost more things. It's harder to get back up, increasingly harder to get housing, to get a job, to get off the streets. And for minor offenses like being unhoused, right? The solution to then house you in a jail and discharge you back to the streets after we paid for the privilege of jailing you and cause psychological and actual harm to you as an atrocity. So I think that's a step in the wrong direction. I think we know what is the value of housing first approaches and other approaches that are based in science to actually helping people improve their self-efficacy and have the tools and resources to make meaningful change. It's there. Dr. Blutenthal's done the research now almost 4 decades. I'm sorry to age you.
Soon, by the time I'm done.
And so we don't need to keep proving it. We know what already works, and we need to do more of what works instead of this, very reactionary approach to investing in things that we know cause death. We know when folks leave criminal justice settings, they're up to 10 times more likely to overdose and die. So this is not a remedy, and we need to do more of what works and less of what doesn't.
Dr. Bluthenthal?
Here. Yeah, I think the kick I'm on right now is, this idea of giving people resources for the kind of behavior change we'd like to see happen. And the simplest way, the program that's available to describe that is this Trieste model, where, they sort of assign a cash amount of money to a person with a severe mental illness or behavioral health problem, and they've got a case manager, and then they could spend that money however they want to help that person get better. And sometimes it's family reunification. Sometimes it's music lessons. Sometimes it's therapy. Sometimes it's a medication. Sometimes it's a little of all of those things. But, we need to move to a place where we're empowering people to be good stewards of their own health. And we need to give them the resources to get there because we're in play. The term that Dr. Herrera was referring to earlier, that Dr. Ganesh came up, which is people are structurally disempowered, right? Incarceration structurally disempowers them. Child Protective Services structurally disempowers them. So we've got to power them up. They need those resources. They need creativity and flexibility. And then they need time, right? They need those positive connections and time, and let that run out and see what we get. Because I think at the end of the day, if we invest in people, that has a great return on investment. And we're really not doing that. And I'd love to see us get to a place where that's really the main policy. And then we have these other things out there. We can still put people in jail if they're really running amok. But let's not start with that.
Yeah, I agree. I think if it were up to me as well, I think I would want to revisit Prop 1 and SB 43, not necessarily change it. I think that there needs to be some minor tweaks. I think that it went too fast. And I think that there should be a conversation with elected officials and involving mental health consultants in that conversation. Ending on a positive note, looking forward, what gives you hope about prevention and overdose regarding just improving health equity?
I mean, I've been really excited. I feel like we've reached or we're getting close to parity with substance use treatment in the state through the CalAIM program, which is something I never imagined would happen. I've been with Vanessa Ramos. We've been giving these talks around the state to drug treatment providers. And I was in Ukiah, and I sort of just threw out, hey, are people able to get treatment on demand? And they're like, yeah. I was in Long Beach, and Gary Tsai, who's the guy who's in charge of that in LA County, he's like, yeah, wait times are gone. So I'd love to see that happen for mental health services, which are, sort of upstream of the substance use thing. So we, if we had a circumstance where people were getting the mental health services they need, we'd actually need less drug treatment, because a lot of the substance use is sort of refractory from serious and other kinds of mental health.
Dr. Herrera?
Something that's really exciting for me that we're seeing on the ground is this shift to direct to inject as how you can initiate MOUD, so that folks are not experiencing as severe withdrawal during the process of onboarding. And we're really excited that this could help to overcome some of the barriers people have been experiencing in this process of trying to seek recovery through medication for opioid use disorder. And so we're trying to increase the psychoeducation awareness and overcome people's previous negative experiences, trying to get on Suboxone, again, especially unhoused without those facilitative conditions to help them move through the withdrawal process. So I think it's exciting that, people are still invested in science and medicine, and that they care about people's experiences and want them to live. And they keep trying to pursue different ways to help people in a way that's actually going to make change in their life, because Suboxone works. Once you get on it, it's an effective medication. It's gold standard.
It is.
But it's not working for a group of people because they aren't able to move through the process of really painful withdrawal symptoms and start it. So they aren't able to really effectively access that treatment. So that, seeing addiction medicine continuing to try to improve its patient care, it's been really exciting. And I hope it empowers patients to be able to take charge of their lives.
Dr. Herrera, Dr. Bluthenthal, any final thoughts before we end our episode? Fight on. Fight on. Fight on. There we go. Awesome. And Dr. Bluthenthal, where could people find you? Where could people find your research?
PubMed. I got a lot of stuff on that. ResearchGate, if you type my name in. I'm chair of the Department of Population and Public Health Sciences at the Keck School of Medicine at USC. So, and then there's only one Ricky Bluthenthal. So I am pretty easy to find if you want.
There you go. That should be trademarked right there. Ladies and gentlemen, Dr. Ricky Bluthenthal and my awesome co-host, Dr. Ashleigh Herrera. This is our second episode of our Destigmatized Mental Health Podcast, Hope in the Valley series. I would like to thank you both so much for your time. Really appreciate it.
Thank
you. You're welcome. Thanks.